Okay, we'll go ahead and restart our meeting. I will take roll call real quick. Can I start with you again, Cheryl?
Cheryl Butler.
Jake Patel.
Jason Weiss.
Song O.
And Debbie Veal. Okay, we're steaming along to agenda item number 6, which is discussion and consideration of the currently authorized duties for pharmacy technicians and possible changes, including discussion of summary information received during the listening sessions and surveys that we conducted. So relevant law, I just kind of want to go through background. Relevant law provides, for, has a definition of a technician as, excuse me, an individual who assists a pharmacist in a pharmacy in the performance of his or her duties. And specifically, the duties currently include removing the drug from stock, counting, pouring, or mixing pharmaceuticals, placing the product into a container, affixing labels to the container, packaging, and repackaging. So those are the current, we don't have very many authorized duties, and those are currently them for a technician. And I feel like I'd be remiss if I didn't also say in a pharmacy we also have non-licensed individuals that I think the lingo we normally use in the pharmacies, we call them clerks. And they can do even less than that. They can't do any of those things. So we also had, let me just kind of go over our listening sessions. So in preparation for the summit, we did conduct 12 listening sessions over a 5-week period. Some of them were for technicians, geared towards technicians. Some of them were geared towards pharmacists. We did a variety of days, variety of times, so we could try to get as many people as possible. We did have the licensees register for listening sessions, and probably the one regret that we had is that we limited the registration, and we found that people who registered didn't always attend. So, we had, I think, 50 slots, and there were times where, we had maybe 10 or 20 people appear. 30 people registered, because I think they were all, for the most part, all fully registered. And so that's probably one of the regrets, is maybe if it's ever done again, I don't know, maybe you don't put a cap on it. But myself, I was part of all the listening sessions, as was President O. He also listened into all the listening sessions, and I believe all the licensing committee members listened into at least one, so they could just kind of get a flavor of how they went. Some people were very willing to speak. We had, in every listening session, we had individuals who listened and didn't provide any kind of feedback, which was fine. We only asked that if you want to just listen, please just go do the survey, because we really were just trying to solicit information back. And we were, specifically, we had specific questions that we went through, and the questions for each group were exactly what was on their survey, and the questions between the pharmacists and the technicians were very similar, more applicable like to their job situation. And so we, basically asked them for, what changes they thought we should be made, if any. And we, when you go through the materials, you'll see that there, in both groups, there were some people who said no changes were necessary. So what I think, in kind of working with the executive officer, Ms. Sodergren, I think what we thought the best way to do is kind of break down the most common topics into the sections and talk about them. And so as we begin to look at the possible duties, like I mentioned, there were in both groups some people who thought that there was no need to make any changes at all. With that said, the first group of items we kind of want to focus on are, and these came out of the survey and the listening sessions. Potentially administering vaccines, considering if we want to add these duties to the technician, administering vaccines and kind of one of the common comments were, there was a lot of the technicians especially liked administering vaccines, which I was surprised at, because I was thinking I was going to hear it from the pharmacists and the technicians be no, but it was the technicians seemed to be very supportive of administering vaccines. And one of the common comments was more than just the flu and COVID that they've been doing. Authority to receive verbal prescriptions as well as refill prescriptions, prescription transfers, and also clarification, being able to call the doctor and obtain clarification of prescriptions. Authority to screen for patient consultation or for the pharmacy technician to accept the patient's indication that they did not want to receive a consultation from the pharmacist. Authority for the pharmacy technicians to provide consultation on over-the-counter medications. Honestly, that's probably one that I'm not sure I'm comfortable with, because I think there's a lot of clinical pieces there, but that was one that quite a few technicians thought they should be able to, that should be considered. Provisions to allow for a pharmacy technician to create a medication history list. Final product verification, I believe Mr. Cover talked about this a little bit in his Tech discussion. There's also comments around remote processing, reconstitution of antibiotics, and just as a side note, Tech we're going to take as a separate item, so we'll talk about that in a minute, as well as remote processing. We're going to talk about that also in a minute. So, you know, now I'm going to ask just the board members first, based on, you know, what you read, looking at the surveys. I don't know, I'm just interested in your feedback on this list. And, you know, any items in this list that you think, you know, would be reasonable to move forward with, and then we will ask for public comment both here and on the Webex. Do you want to start, Tom? Sure.
Thank you. And I just want to thank all the technicians and pharmacists for participating in this survey. It's very insightful. I think one of the things we can really look at is the vaccination. So that was, you know, good to hear that a lot of folks are enjoying doing it and that they are happy providing it. But of course, I want to make sure that we have good guardrails to ensure that they are done safely. Certain interesting things, authority to receive verbal prescription. I mean, I'm not sure how useful that those would be because of the electronic prescription requirements, but I think we can consider looking into that. I think that's where we start. I just want to kind of, you know, see where we can go and step-by-step process. So not just everything into one big basket and try to jam everything through. I think we just kind of step-by-step approach. And with the vaccinations, it seems like, you know, we've had a good success so far. So maybe looking into that, but requiring certain assistance so that it actually helps pharmacists and technicians to take care of patients. So
I'd like to ask a question about that.
I just want to make one comment, and that is that what we're talking about, we're going to be changing their duty, so whatever happens will require statutory changes.
Okay.
So my only worry in doing, you know, being too step by step is, I think, you know, then we're going to end up going back to the legislature every year, and I think whatever we do, I have a feeling we might get some pushback from other healthcare professionals because they always feel like we're stepping on their toes. But just a side comment. I'm sorry, Cheryl, what were you going to say?
No, I question about the vaccines in the sense that my understanding that were techs who volunteered, who wanted to do vaccines, were the ones that were doing vaccines, that not all techs wanted to do vaccines or felt comfortable with it, so they didn't have to. So my question is there some way we could leave that there? You know, because you know, you have a variety of techs, some coming right out of school, some that's been there, and there are some, I just don't feel like we should make any kind of requirement, but those who have had training and they enjoy it, and then, you know, you talk to others and maybe inspire them to want to do it. I just feel that way. And then also, you know, when I hear the pharmacist, like the one that came on today, that says, I'm in one room and that person's in another room, but I'm still responsible for what happens there. I'm just hoping that they're, you know, if we increase in the use of techs, that somehow there's some protection there for the pharmacist. That's all. That's just my comment.
Yeah. I think if I make a suggestion, maybe we stay a little bit high level and decide what do we want to tackle, and then honestly probably it'd be a subsequent meeting like with vaccines, because I agree with you. You're probably going to need training. You're probably going to need rules around it. Yeah. But is vaccine something we want to, you know, consider, like put on the board to move forward?
I could definitely see that.
Yeah, and then have the committee kind of they're going to have to nail down.
Okay.
So let's, you know, maybe we try to do that.
Okay.
Jake, do you have any comments? I'm kind of doing a zigzag here.
Sure. ACIP recommended vaccines should be allowed. CLIA waive point of care testing. I also feel that tech for product verification. And as far as oral orders is concerned and transfer of prescriptions, my practical take as a practitioner, I don't currently actively practice, but when you take an oral order, a lot of times it's clarification with what President O said, that now with e-scripts, not everything is being transmitted, but these calls are made to clarify a direction or a quantity. And what happens in practical life is a technician is making this call, they get the appropriate party online, and then they go, pharmacist, come here. So you can hear with your ears, and all they're saying is, yes, change it to 2-3 times a day or whatever, quantity, different changes. So I feel that if you compare some of this task to providing immunization, that's less complex. It's more common sense, so to speak. And again, under direct supervision of a pharmacist, some of the verbiage we have for even vaccinations that, you know, got to be under supervision. And if the pharmacist have confidence in that particular technician for the day, could be a floater, could be anybody, right? And so I feel that, yes, oral orders should be part of that, and transferring prescriptions in this day and age, it's not phone to phone. Nobody has that time. It's usually printing out something from computer system and faxing it over. So we could articulate the language where it specifies what was done, because, you know, nobody is giving oral prescription transfers. So again, I feel that we should be able to work regulations where they are able to provide all vaccines, CLIA waive POCT, even do oral orders and transfer prescriptions, and tech verification.
What do you think about the ability to screen for consultation and taking declines? That was actually, I don't remember any of the pharmacists bringing it up, but the technicians brought it up.
Ability to consult for OTCs?
Not consult, to ask. Mr. Patel, would you like to talk to the pharmacist? And if you say no, that's good, because, you know, technically right now, the pharmacist has to hear the no, and the technician technically isn't supposed to even ask the question. So the techs felt like that was, and I don't want to paraphrase but we heard it enough that, you know, that they felt like it was like, Song, come over here. Okay, you heard him say, okay, you can go back. That they felt like it was kind of a waste. And so that's why they thought
that is a waste. And And again, we would have to be careful about lunch period when the pharmacist is not there, so directly supervising and all that. But yes, absolutely, if the pharmacist is present.
I mean, granted, we don't want that to be an excuse for not pushing for consultation or allowing techs to just willy-nilly. And go ahead.
I just wanted to, like, if that is something that the committee is, if that's an area that you're interested in exploring, I think we have to look at the patient consultation requirements, because I'm not quite sure that that could be effectuated without additional changes in the law, because I believe under the law, a pharmacist is required to initiate. So I don't think it would require more than just changing tech duties if the committee's interested in that.
Okay. And then the other one is providing OTC consultation. That was another one that came up more often than I was, and I was kind of surprised, and I guess just from my viewpoint, I was like, no, but I wasn't sure.
Go ahead.
I think that's when it's just, as regulators and, you know, enforcers of the rules, how can we really enforce it? I just can't even figure out how we would texturize that allowance in the law. Like, okay, if it's an over-the-counter item, a technician can consult. I just, you know, because I saw comments saying, like, anyone can read the box, but that's not really what's going on.
There's actually one of the pharmacists said that he listened to a technician who went and got, like, Motrin and some sort of stomach medication for her parent, and just happened to say to the pharmacist, yeah, I'm doing this, and the pharmacist said, oh, my God, don't do that, because, you know. Jason, I've totally skipped over you.
No, that's fine, Madam Chair. A lot of these things, I think as a public member, I really only have, like, public ideas in face. One, I didn't know that techs weren't allowed to ask a declination. I always check a box, and you know, I use these medications enough. So I think that'd be fine to advance. I think it'd be appropriate. As far as an over-the-counter, I don't think that the board should explicitly invest that authority into techs. I think that's getting into dangerous territory of how your family has always done things. But I think much of this, I think I would be open. It's all in how we approach adding these acceptable tasks to the tech's authority. And then I think highlighting in what our document says here, it's in the oversight that pharmacists do feel overburdened. I think that is a big concern. But techs, for the most part, many of them feel like they do have that oversight. And I'm curious to see if what Cheryl brought up, are we getting this feedback from techs that are already doing vaccines or already advanced, and thus they do feel good about these additional duties? And that's what we're hearing. So what are we hearing from, like, the general tech population? I think it is really would be helpful and good for us to suss out.
And one thing, kind of going back to what I heard on the calls, is I was surprised that the techs wanted to do it. Now, there were a couple of them that explicitly called out, I have friends that don't like to do it. And there was definitely some pharmacists who also said, I don't want every one of my techs to do it. So I think that gets into, you know, into the weeds that we're not going to get into today. But so I think, you know, the future committee is going to have to, that's part of what they're going to have to parse out.
As far as recommending OTCs by technicians, I don't feel comfortable adding that role myself, because that does get complex with different disease states, and there's a lot more to it than just recommending, let's say, a pain medication.
Yeah.
It requires a little bit more than that of clinical knowledge.
Did you have anything else?
No, I just wanted to agree with that. I
Okay.
agree with that simply because we have a lot of a lot of prescription drugs that have gone OTC, and there were a reason why they were prescription in the first place. So I totally agree.
Okay.
What Jake said.
So it seems like for the most part we're kind of okay with this list. I'll open it up to the public now. We're going to get into deeper detail on tech, check tech, and even oversight. We're going to get in a little bit more detail, and remote processing, our future discussions that we're going to have today. Okay, got them lined up. Very good.
Good afternoon. I'm Tom Harper. I'm a technician. So as you guys mentioned, so I was one of the first technicians that actually went to do the immunization training, and I felt really comfortable. I felt it was needed. When UC Davis opened up our vaccine clinics, we didn't have enough nurses and physicians to staff those clinics. So when they opened it up to the techs, it gave me the opportunity to help out those colleagues who were already stretched thin. But again, I think when you guys put that in there, it has to be with appropriate training. I don't think a brand new technician who is right out of school should be mandated or even probably authorized to do immunizations, because I don't think they're comfortable enough to even know how to do it, how to perform it. So I think when you do this, or if you do it, it has to be with the appropriate training. Same thing with what Jig said with the point of care testing. I think, a lot of, especially the retail sites, if you can have a patient come into the pharmacy in the retail setting and do a nose swab for influenza, for COVID, I think that, prevents the pharmacist from having to come out of the counter to, perform that test. I mean, patients can do it themselves now, but, with point of care testing and the CLIA wave testing, I think expanding those for the technicians, again, with appropriate training. So as Dr. Berkeley mentioned, PTCB and ASHP have these training programs. I have taken them both over the last year, just so I can, expand my knowledge base and, help out the pharmacists as much as I possibly can. But I don't think, as Lavenza said, I don't think it should be mandated. I think the technicians should have the opportunity to perform these tasks, but it should be mandated. Thank you.
Hello, my name is Jeannie Lee. I have 4 things I want to talk about. The OTC, to me, I've been a technician for many, many years. My response to that would be a no, for technicians not to do OTC consultation out there. Even my family comes to me and asks me that. I'm like, I'm not a pharmacist, go ask somebody else, because I don't want to give them the wrong information, even though I know it, but I don't know other circumstances they might be going through. Now, the verbal orders, I agree, yes and no. I would say yes, if we can take the verbal orders, we write down whatever they're saying, hand it over to the pharmacist just reads whatever I write, the doctor's going to say yes or no. I would say no to the people that are new to the field, because they don't know exactly what they're writing. So that would be a yes and no. For the vaccines, now I asked everybody at my work if they would be willing to do that. Majority of the people said no, because first we have to take a learning, go to a learning site, pay for it. Technicians don't have that kind of money to pay for it. And there's not in law that this is going to be something that's going to be continued. If it's just a one-time thing because of COVID, it's not worth it to them. So majority of them said no. Now, for the vaccines, of the people that say, yeah, they want to do it, then I think that should be put into law where, yeah, they go to class, get certified, and then they can do the vaccinations. Now, for your learning sessions, I really appreciate it, Deborah, but for some reason, I never got notice about this thing until Tom told me about it. And I logged in, but I didn't read it through, and I logged in and I applied for every single session. I wasn't able to get into any of the calls. So that's probably why you have lack of participation. And for future, if you guys can send out a notice, hey, you have a meeting tomorrow, that would have been helpful. Thank you.
Thank you.
Hi, Lindsay Goldhorn with the California Retailers Association, National Association of Chain Drugstores, and nice to see all of you in person. I think most of the time I've been on Webex, so nice to see you and hopefully meet some of you. So first, really happy to be a part of this summit, and I really appreciate the listening sessions. We weren't involved, but it sounds like you got a lot of good feedback. I reviewed the results and also was happy to see that techs do want to do vaccines. I think we would absolutely support that. As you all know, there's a waiver in place right now that allows this, and even though the governor has rolled back, I think 90% of the COVID waivers, this one is still in place because he recognizes the need for it. Sorry, yep, is that better? So most of the COVID orders are gone, but the vaccine orders are still in place, as well as the testing orders because we still need it. And obviously, COVID is not going anywhere. I think we all know that. So being able to have this authorization for techs to do vaccines, I think, will be important. And I agree with the rest of you. I think that the other duties, verbal transfers, would be great. I think a lot of it comes down to a pharmacist delegation, and a pharmacist being able to know a tech and see and decide if a tech has the ability to do this. And also, I appreciate techs' desire to do things, and I know that there are training programs in place for techs, especially with vaccines. And testing, and so definitely want to be a part of those discussions, but just generally speaking, we absolutely support techs being able to do additional duties, including vaccinations and remote processing as well, but we'll be talking about that later, I think.
Yes, we will. Thanks, Lindsay.
Hi, Shane DeSaltero, University of California. So in regard to it sounds like a lot of people here from different angles are kind of coming to the same conclusion. It sounds like it's kind of getting on the same page. In terms of the question about wanting to do vaccines and other sorts of things, we have some research that shows that the number one driver of pharmacists, of technicians wanting to do these things, is a supportive pharmacist. So that is the principal driver of whether a technician wants to do these things, is if they feel that they're being supported. So the other, I would agree with the others with regards to OTCs, not probably, because that requires clinical judgment. So that's always been, I think, a major hurdle that, well, not a hurdle, but something that we should probably allow to impede in terms of practice scope, but some of these other things don't allow clinical judgment. And in regards to people mention appropriate training and so forth, and I would agree. And I know you said you're not going to get into the weeds today, but I know just prior to the pandemic there was another session like this, and it was regarding a laddering or advanced technician mechanism. And it seems to me what other people are saying as well is that these things are probably best delegated to a technician with experience and with certification. So in other words, some sort of laddering mechanism. And I know that, I don't know if we need to speak on behalf of all of them today, but I know in the past when there have been meetings, not only have academics and technicians said the same thing, but even some of our large employers, the health systems, the chains and whatnot, have all been in favor of this sort of thing. Where we have a laddering mechanism, because I'm very sensitive to the comments that someone made earlier this morning on Webex, that we don't create another barrier for entry. So, it shouldn't take that much, so to speak, to just become an entry-level technician. But when it comes to more advanced, we need some sort of laddering mechanism and things in place to ensure safety and I actually have something for technicians to shoot for anyway, which is what they really want in terms of their career goals.
Thank you, Shane. And that's probably something the committee needs to also consider, is like advance if you want to have different layers of technicians.
Hello there, Mark Johnson again, to continue on from my thoughts from this morning. So most states, so the new trend is to go towards a delegation model. I know your materials listed 8 or 10 states that have already enacted that. Arizona can now be added to that list. At least the Board of Pharmacy has approved it. It's going through the administrative process to become finalized. So that's where a pharmacist can determine that the techs who they are on duty with can perform any practice, I'll say, except for counseling and except for DUR. Those are always reserved for a pharmacist. But every other duty, literally, Arizona and these other states, allow the pharmacist to determine if the tech that's working with them has the experience, has the training, and is able to do it. some techs may be perfectly competent to stick a piece of paper in a fax machine and transfer a script, but that's it. Others may be able to do verification without a pharmacist's final check. It's up to the pharmacist on duty to assess the techs that they work with. It is the newest model. And again, the goal is to, free pharmacists up to be able to do these expanded duties. California has such great laws when it comes to smoking cessation. Yeah. Okay, thank you. Pharmacists, California has such great laws when it comes to pharmacists' expanded duties like smoking cessation and HIV prophylaxis, and I could go on and on, travel meds, and I don't think they're being offered as they could be if the pharmacists were freed up to be able to provide those solutions. So that's really the ultimate goal. In the last of my session here, I did want to talk real quickly about point-of-care testing. Federal CLIA waive law requires a CLIA waive certificate in order for the facility to perform point-of-care testing. They require a lab director, and a pharmacist can qualify as a lab director. And then the lab director determines who's qualified to be able to, through training, perform the tests. So a doctor's office staff does the test, a pharmacist's technicians can do the staff. According to federal law, it's laws like California that restrict beyond what the feds allow.
Thank you, Mark. Okay, I do not see any other people wanting to speak at Market Street. So, moderator, could you please open up Webex and see if we have any public on Webex that would like to speak?
Absolutely, and as a reminder, you can use that Q&A panel. Click on the Q&A icon and send the word comment. Or for our call-in users, you may dial *3 to raise your hand. Our first comment comes from Christina Randolph-Martel. Christina, I've sent the request to unmute your microphone.
Pharmacy, that a outpatient pharmacy or an inpatient pharmacy. With regards to all of these discussions.
Wait just a minute, Christina. Can you hold off just for a sec? Can we turn her up? Well, we can kind of hear you, but not real well. So
I'm sorry. Is that any better?
There we go. Yep,
okay.
Now we can hear you. Perfect.
I'm so sorry. So to go back, my question is very specific. In all of these discussions that we're having with regards to pharmacy technicians, in all of the discussions that we're having and what these outcomes may mean in different things, I keep coming back to, we're talking about a lot of outpatient or inpatient settings where we're in a licensed pharmacy. What about those technicians that are working in a non-licensed setting, like in a clinic under a physician work group? How does that apply to technicians in those settings?
Ann or Eileen, I don't know. Can we even go there? Did you hear her question? Like, we're talking about technicians in a licensed pharmacy. What about if they're in a clinic or working under a physician?
I think it's, so I would suggest looking at the definition of a pharmacy technician, because technically that is in a licensed pharmacy. So if it's outside of a licensed pharmacy, it's an individual performing tasks. That individual may also possess a technician license, but it is not their technician license that they are working under.
Correct, and they also don't need necessarily a technician license either in those settings. It's not a requirement in some of those, but the pharmacy technician, so if they want more detailed, I think we're having some discussions at the next meeting, correct, about multi-distant compounding, but we can look at some of that if you wanted to expand beyond that, but it's not the definition of a pharmacy technician.
And you're referencing the enforcement meeting tomorrow? Okay.
Thank you for your clarification. I appreciate it.
Yeah, and actually, you know, when we started off this section, the definition of a pharmacy technician is an individual who assists a pharmacist in a pharmacy in performance of his or her pharmacy-related duties. So good job, Ann. Good memory. Okay, moderator, do we have anybody else?
We do. Our next comment comes from Johnny Lamb. Johnny, I've sent the request to unmute your microphone.
Hello?
We can hear you.
Oh, okay. Good. Chairperson Bios and the members of the committee, good afternoon. My name is Johnny Lam. I am a licensed pharmacy technician here in California. I'm also the chair of the Pharmacy Technician Special Interest Group with the California Pharmacist Association. I appreciate the opportunity to comment today on behalf of CPHA. CPHA respects and values the role of pharmacy technicians as members of the pharmacy team, as is evident through our existing policy statements. CPHA supports the role of any advanced pharmacy technician to enhance the ability for the pharmacist to provide patient-centered care. We hope that by utilizing existing training structure from national certifications such as PTCB as qualifier for advanced pharmacy technician licensure, it would allow the Board of Pharmacy to maintain dependable and verifiable continuing education requirements without the need to recreate any new administrative structure in California. In regards to vaccinations, the pandemic has taught us many lessons, one of which is that it is imperative that we utilize ancillary staff in order to meet the healthcare needs of our communities. A prime example was the role that pharmacy technicians played in providing COVID-19 vaccinations to our communities during the COVID-19 pandemic. Once we were provided the temporary authority to administer the COVID-19 vaccines, hundreds of pharmacy technicians signed up for the training. We have vaccinated thousands of Californians alongside pharmacists safely. Therefore, we would encourage the licensing committee to consider including the authority to administer all FDA-approved or authorized vaccines with ACIP recommendations under direct pharmacist supervision to align with the most recent CPHA sponsored bill, AB 1064, authored by Assembly member Vince Fong. The nationally recognized training program that we all took and completed by most pharmacy technicians covered all aspects of both intramuscular and subcutaneous injections and would be consistent with the focus of increased access to preventable disease for our communities. While technicians with proper training are able to safely vaccinate, the board must be firm in emphasizing that pharmacists must be allowed to determine without corporate influence which technicians on their team they entrust these new responsibilities with. So with that, thank you.
Perfect timing, Johnny. You just hit your 2 minutes.
Thank you
very much. Thank you.
Our next comment comes from Jazzy Graywall. Jazzy, I've sent the request to unmute your microphone.
Graywall, Legislative Director with the United Food and Commercial Workers Western States Council. UFCW represents several thousand pharmacists and pharmacy technicians throughout the state in the grocery and drug retail setting. I just wanted to make a couple comments. I know the board conducted a survey around expanding the scope of practice for pharmacy technicians, and I think while we're just seeing the survey results, I really hope that this board, like with the workforce survey results, forms an ad hoc committee to really be able to talk through what those results showed and what the significant findings were of the participants, and really break that down by setting, by practice care setting. So we're really talking about the unique needs of every care setting and how pharmacy technicians can play a supportive role in that process. I know this was mentioned previously by one of my colleagues, but as pharmacy technicians start to take on more expanded duty, it's really important that we are appropriately compensating those pharmacy technicians for the additional training that they have to go through, the additional responsibilities, the additional liability that they have when it comes to their expanded scope of practice. Also, the voluntary piece is really important. Not all pharmacy technicians want to administer vaccinations or want to expand their scope of duty, and so really making sure that's voluntary, but also getting the pharmacist's input where liability really falls upon their shoulders if something goes wrong. I think it's really important when we're talking about supervision. Some of the vaccinations happen in a clinical room with a closed door. And so how does supervision look like on behalf of the pharmacist who might be behind the counter, but then have pharmacy technicians who are in a clinical room? And also be mindful of the fact that pharmacists who have pharmacy technicians, making sure they're not losing their supportive staff behind the pharmacy counter, but are getting additional support when it comes to expanded duties like vaccinations. We know from our members that there is not enough support of the pharmacist, so we want to make sure that the support pharmacists have, they're not losing that, and that there is appropriate supervision and oversight of the pharmacy technicians if they're in a separate space within the pharmacy administering vaccinations. Thank you.
Thanks, Jazzy. You too just hit your 2 minutes. That was perfect. Thank you for your comment.
Our next comment comes from Lori Walmsley. Lori, I see you're unmuted.
Good afternoon, board members. Chairwoman Beal, thank you for the opportunity to speak. Lori Walmsley on behalf of Walgreens. And we are also supportive of the items that you've discussed today. I agree with you that the consultation piece of over-the-counter is probably a little bit too far. As a pharmacist myself, I don't feel like I would have had any technicians that I felt like were probably to quite that level of competency, since there is a number of clinical decisions that need to be made kind of in the moment. But otherwise, we're supportive of the other comments and of the duties as listed, and appreciate the conversation and look forward to further discussions. Thank you.
Thanks, Lori.
Our next comment comes from Jennifer Courtney. Jennifer, I've sent the request to unmute your microphone.
Hear me? I'm sorry.
We can.
Yes.
Okay. Thank you so much. Hi, I'm Jennifer Courtney. I am also with CPHA Speaker-elect, but I'm talking on behalf of myself. I'm also an assistant professor at California North State University College of Pharmacy, and also their IPPE director. One thing that I do want to point out, and I love that you guys are talking about the patient counseling portion of the OTC products. I actually teach the self-care course at Cal North State. There is so much more to OTC products than we know, and there's even exclusion criteria, and I hound on my students about that and making sure that they know when to refer because something else is going on, not making any kind of diagnoses ourselves and not stepping out of our that Johnny Lamb had said, including there was some comments earlier about transferring over the phone. We don't do anymore. We actually do that all the time. I work for an independent, as well as take new prescriptions over the phone. The law does state that each physician and pharmacy has to have the ability to send it electronically. Not all doctors are doing that, especially our hospice doctors. We also treat mostly and mainly mental health facilities in the area, and they don't like to use
Jennifer, we lost you.
Can you hear me now?
Jennifer, we lost your last train of thought. After you were talking about the hospice doctors don't always prescribe. After that, we lost you.
Oh, I was just saying also our mental health facility. I work at an independent where we specialize in mental health, and those doctors don't as well. So I want to stand up support for not only that, but of course, the vaccinations, any vaccinations, whether it's sub-Q or IM, under, of course, the pharmacist's, clinical judgment. And I do not think that mixing would be the best idea of vaccines. I think that pharmacists just still have to mix because there are so many delicate things when mixing vaccines. But I do stand in total support of technicians and the expanded role, and hopefully making that an advanced practice for pharmacy techs. Thank you.
Thank you, Jennifer.
And our next comment comes from Laura Jensen. Laura, I've sent the request to unmute your microphone.
Appreciate the time. I wanted to comment on a comment from one of the previous callers who works in a clinical setting. I'm also a clinical pharmacy technician, and as you guys have mentioned, perhaps clinical pharmacy doesn't fall under the definition of a pharmacy technician at this time, but I think possibly we could look at expanding the definition of a pharmacy technician, because as we are expanding the scope of it, I think we see that technicians are serving in a lot of different areas within the pharmacy department than we previously were, and I think that should be represented in the definition of what a pharmacy technician is and what they can do and where they serve. Thank you.
Thank you, Laura.
I am not, oh, next comment comes from Jeff Olson. Jeff, I've sent the request to unmute your microphone.
Just checking. Can you hear me?
We can hear you.
Perfect. I do want to echo Johnny and Laura's comments. I think it's really important for both of those. I think that the areas where technicians serve is not just an outpatient pharmacy or an inpatient pharmacy, but we also serve in any area where the pharmacist is. So I think the definition is definitely up for review and maybe updating. Pharmacy technicians can serve a lot of different functions in the pharmacy. Right now, we don't have the ability to help our pharmacists to provide better care, to be able to help the communities with vaccinations. And as COVID continues to grow and continue to be an issue, as well as flu, our role in the pharmacy in our communities is really important. So I do support both of their comments, and I think that's all I wanted to say. Thank you so much.
Thank you, Jeff.
And with that, that looks like our last request for comment this round.
Thank you, Ms. Moderator. Okay, so members, now that we've kind of talked amongst ourselves, we've heard from the public, let me just kind of summarize what I heard, and I have one question I think we might need to just talk through a little bit. But it seemed like people, for the most part, once again, high-level details are going to have to be figured out in future meetings. But that we'd like to look at adding these duties, and that's administering vaccines, receive verbal prescriptions, refills, and transfers. I think clarifications also. Then we also, I think we touched on, and let me know if that we might want to discuss at a future meeting the consultation piece, understanding what the executive officers said, that it's a little bit more complicated than just adding it as a duty, but that might also need to be looked at. The one thing that came up a couple times, Jig, you started it, and that is point of care testing. I think we heard a couple people mention it. Is that something we also want to add to this list at this point in time? Yes, I see head shaking, yes, okay. And the main thing we're scratching off here is consultation on OTCs. Final product verifications on this list, but I think we're going to hit that when we do tech, so I'm kind of pushing that to the side. All right, so is that kind of trying to put some guide wires there for the staff? I mean, I guess we'll have to, wrap it up at the end, but do you have any, does that seem clear?
Yeah, I think that where there appears to be consensus is vaccines, receiving verbal prescriptions and clarifications and transfers, and then point of care testing, and then a note that the consultation issue needs to be further discussed.
Yep. Okay. Okay, so now moving on to functions that would allow supervision of one technician by another technician. So that was also included in the the surveys. It was also part of the listening sessions, and it's also part of the materials that we have here. So I guess, and I think the main thing that we heard that was used for was product verification, final product verification. During the listening sessions, they also, there's a lot of technicians that talked about using it like a more senior tech to train. I don't really know, that's probably really not tech. So interested in your thoughts, board members first, as far as tech for product verification. And I kind of reading through, I think, some of the studies and maybe adding a little bit of my, my thoughts is it kind of almost needs to be final product verification, because if a tech checks a tech and then a pharmacy checks what the tech checked the tech on, like, well, there's no need to even have tech because you're just adding another step. So I think we have to either be comfortable that a tech would check a tech for, it's only for the product verification. Pharmacists would still be doing their clinical review or their DUR review of the prescription itself, but it'd be just a tech of the product. Once again, if it's a pharmacist checking the tech who checked the tech, that doesn't really bias anything. That doesn't free up the pharmacist. So, Cheryl, do you want to start? What your thoughts are, or you want to start down here and come to you?
Yeah, Madam Chair, if you don't mind, where are we saving, or as a public member, where do we currently stand on this, and what is the tech going to skip? If
so
you could, for my benefit.
The tech frees up the pharmacist, because a lot of times, I mean, a lot of it's automated anymore, or using scanners to make sure that you scan the bottle, you scan the label. When the pharmacist is doing their DUR, a lot of times there's pictures of the pills and everything. So it just frees up the pharmacist from what at one time wasn't a non-discretionary job, but now it really is. It's just kind of matching. So it's to free up the pharmacist. Because right now, whatever a technician touches, the pharmacist is double checking. And so it's just having another. The benefit, I think, is, and I think the studies show, is just having a second pair of eyes, check it. And this is going to get into the weeds. The second pair of eyes needs to be an educated pair of eyes, but it doesn't necessarily have to be a pharmacist, I believe.
Okay. No, I do want to say something about that.
Okay.
I don't know. I still feel that ultimately the pharmacist is responsible. And so I'm kind of like in the middle on this one, because I still, but I haven't been out there, but I know that 90% of the pharmacists are unhappy with working conditions, and when I think about that and consider the fact of so many of them dealing with anxiety and stress now, I can see, if this is going to help, but I'm also thinking about liability. So I'm kind of torn.
So Jason, just wanted to further explain what Debbie said. A technician fills a prescription, count pours, and at the last step that a pharmacist does is product verification, where you're checking that the right color imprint, the right medication got in there, and the quantity is correct. Those are the only two steps. And quantity is just a guesstimate. That looks like 30. They're not recounting it, or if it's a liquid, they're looking at the color of it. It's usually in a bottle, so you can check. So the step is basically looking at the screen and saying, okay, green 593, green 593, looks like 30, okay. And so, my thoughts on the process is, I think with the technology that's out there in, I would say, 90% of the pharmacies, that step could be given to a technician, and that technician should be certified, given that advanced pharmacy technician certification, X amount of years of experience working in the pharmacy, so it can be just any technician. The final check should be done by a certified technician. That's my thought.
Okay. Do you have any other comments, Jason, while we're coming down the table?
So I don't want to be negative Nancy here, but I'm just not really feeling this one, unfortunately. I don't see the value much in community setting. I think that's what we're mainly discussing. I just, from my experience, I don't spend much time in product verification if that's what they're saving. I don't think it's worth it for us to go through all the hurdles to allow that practice to happen. I think this is where inpatient setting, which we already allow, much more valuable. So I'm torn. I really don't think that this is valuable in a community pharmacy setting. I think inpatient settings, this is already been utilized, and you could tell me more, but it seems like there's some value there. So I'm more on the side. I think that this is, let's just kind of, see what more duties they could do, and then if this is one of them that could be added on later on. I just think that this is a little bit too, I don't feel comfortable from a pharmacist's perspective that this is one additional duty. And I don't think that this will make me feel better that someone is doing this. I would rather do it myself, so it's kind of one of those things. I'm not there yet. So.
I guess, it seems like this is like one of the things that's the most studied, though. And it seems from the studies that it's, with the tech, checking the tech, it's at, and this is how I've registered in my brain, that it's at or better than the pharmacist checking the tech. So that's the thing that, but I will say it's been a while since I've practiced. So, I don't know, Jig, I don't know, are you in the pharmacy probably more than me?
I am, and the most critical, well, all steps are critical. But if you had to rank them, obviously, data entry is a crucial step, and that is done by technicians today. And if I compare the initial data entry with product verification, the data entry step has more to it than the final product verification step, where we are literally checking for all the oral tablets and capsules, the imprint and the color, and gauging the quantity of the product being dispensed. Whereas data entry, which is being done by clerks, technicians, and that one is, I feel that that's where more errors can happen if a prescription is interpreted incorrectly or directions are put wrong. And then the second set of eyes, obviously, is the pharmacist, but it can go past that. So, again, my point is that data entry is more crucial step than PV, and if product verification, if we are giving product verification to a tech checking another technician's work with X number of experience and advanced pharmacy technician training, then it should be okay.
Question is, where is the pharmacist in that, though? If the tech is putting the information in, and a tech is checking it, and a tech is filling it, where is the pharmacist?
Well, the pharmacist would be checking, like Jig said, he would be checking the input with the DURs. The pharmacist would be checking the prescription is correct on the label.
Data
is only, final is only checking what's in the bottle.
How is that going to save? I mean, I'm checking that, so what's wrong with just checking it and I'm feeling good about it when it goes out the door?
Okay, so this is how I think it. So if you bypass, so the pharmacist checks the prescription with the label, but they don't have to handle, like, the product doesn't actually have to come to them, they don't have to touch it and then have it passed on, because that has been already verified over here. So the pharmacist, before it can be released, the pharmacist still has to do their verification, you know, do their DUR, make sure that that prescription is correctly transcribed into those, that label. So it's,
yeah, because it's been a while since I've been back there, so.
So the pharmacist has to, sorry, go ahead.
Yeah, so, but I see what you mean when you say the color and the number, if that's real clear, you know.
That's all that's the verification is what they're doing. They're not verifying, the label's on the pharmacist.
So data entry, data verification, which is if a clerk or intern or a technician typed a prescription, a pharmacist has to do data verification, which is truing up the prescription against what was typed and what's going to go on the label, which is doctor name to DEA number to SIG directions and quantity and everything else. So it is going through the pharmacist for the most crucial step, including the drug-drug interaction and everything. So, and then it's a matter of counting, pour, and fill, and then another set of eyes checking that it was, in fact, the same product that was supposed to be in there that's in there, so.
And I mean, I remember, you know, you would scan stuff, so, you know, you would know that, okay, I scanned this, and I scanned the label, so I know that that should be good. So it's just that second check to make sure that what I scanned, like what really went in there was what I scanned, and I didn't oopsie. So I think that's what we're talking about.
And I'm so used to checking that it's
so
kind
I
of
know
hard
we're
for me
getting
to see it, but
sort of granular here, I feel like, but we should
Right.
stay in the bigger picture.
Yeah.
And bigger picture, I mean, I just, like I said, what are we trying to really, you know, save pharmacists? I mean, I think there's so many things we could be focusing that'll actually help pharmacists do their job, and in trying to allow tech is how I look at it. There's just so many other things that we could be focusing on. So, I mean, I think this is just one of the piece, but it doesn't, you know, I think talk to pharmacists, they're already so stressed out, and, you know, this is really going to help them be able to do their job more, or is that going to be, you know, make them more stressful? So, I mean, studies are great, but obviously I looked at them. They're small-scale studies. They're at a very different kind of settings. I mean, maybe I would be open to it if we sponsor a study that looks at a real world and seeing what's going on, and if that actually could significantly reduce pharmacists' ability to perform other clinical functions. But I'm just not there. I'm not seeing it, so I think that's where I am.
Yeah.
And President O, some other states did it, right? I feel, was it Idaho? That's doing that. I think that's in law right now, where a technician can check another technician's work on product verification. I don't know, we can look at, you know, how they implement it, or there are a couple other states I feel that I don't know top of my head, but there might be some study out there.
Yeah, I think so I can't put my fingers on it, but one of the materials we had actually had, and I think it's more than like one or two, I think there's quite a few states that allow it. Like you said, hospitals are already doing it, and I guess part of it for me is hospital in California is doing it, and they've found it very effective. So I guess I feel like
I see that as different, though, because I worked hospital pharmacy, and it's like unit dose, and it's being checked again by the nurse. There's a check there in hospital pharmacy.
But if you didn't have tech in the pharmacy before it got up to the nurse, it would be tech, you know, pharmacists would check it before it went up to the floor, so, yeah. Anyway.
May I just say, should it be helpful information? I can't, my memory is not going to pull forward the business, but there is provisions in the law that does allow for a research study, like to promote innovation. And I think that, you know, that was done for the ads, you know, as a precursor to the ads. And I think actually maybe even before tech in hospitals. So I just wanted to throw out that there are provisions for the board to consider that. I think it's done with the School of Pharmacy with a research study. So I just wanted to throw that out there. Should that be helpful?
And, should we hear with the public? Okay. Open for public comment. And once again, we'll start here in, on Market Street, and then we'll move to Webex. Shane.
Shane DeSale, Touro, University of California. Board Member Veal, you're correct. It actually is the most widely studied so-called advanced technician duty. The study of Iowa was just the very first. There have been a number of them since then. In fact, we conducted a study to follow up on the Optimizing Care Model article that you have. We tracked, it was a before-after design, and this was in Kroger pharmacies in Tennessee and Ohio, a few dozen of them, and we saw no difference at all in safety or error rates. And we also were able to enumerate the clinical activities that were undertaken by pharmacies by self-report, whereby the pharmacists reported it. The pharmacists reported drastic reductions in stress and a 225% increase in the number of direct patient care activities they were performing in the stores in Ohio and Tennessee in Kroger. So again, it is widely studied. Not only have we studied it, but since the Andreski study, there have been a number of others, including in chains and other settings. So that Andreski, and with the limitations properly enumerated by the author about it being small independent pharmacies at the time, but since that time, it's been widely studied in other states, in all types of pharmacies, from mass merchandiser to grocery store pharmacies, et cetera.
Thank you, Shane.
Good afternoon, Tom Harper. So I just have to say, you know, I think you guys are talking about two different things here from what I'm hearing is tech on the hospital side, I think is a lot different than on the retail side. I think what you guys are talking about is tech final verification. And I worked in both settings, and as a technician, I wouldn't feel comfortable putting my name on something that another technician had filled without a pharmacist. That's just my opinion. But in the hospital pharmacy, with automation, you're scanning it. Then when the technician checks it, they're checking it off. And then when the technician fills it into the ADM, you're scanning it again. And then when the nurse pulls it out, they're scanning it with the rover before they actually give it to the patient. So there's so many different other verifications using automation that protect that patient to make sure they hit the right medication. So me, I wouldn't feel comfortable with this. I feel also, if you put it as a requirement for the APT, then hospital techs can't do it. So now you're restricting them, and all the hospital techs would need to be APTs. And that's going to add restriction to the hospitals who are already shorthanded with techs, who now have to go back to school and get this new licensure. So I'm fully against at least a tech part. Thank you.
Thank you, Tom. Jenny, how are you?
Jeannie Lee again. So my take on check. I visited this many years ago, way before check happened. I used to work in a hospital. We had the pharmacist chose certain people to do check on unit dose, and they found that the technicians actually did a good job in checking check. But if you're going to do it in the retail, I don't agree, because we have technicians out there in retail who really don't know what they're doing, and they're just filling because they just feel count and pour, but they're not really evaluating what they're filling, what that medication is for. They're just filling. So I don't agree with that portion of check in retail to be passed. But in a hospital setting, there's other avenues. Thank you.
Thanks, Jeannie. Mark.
Hello, Mark Johnston again. I certainly could be supportive of tech. I believe that the studies and documentation show that a technician that's focused on that duty is actually more accurate than a pharmacist who's got so many different duties that they're called away to in the middle of processes. But with all that said, I think tech might be old hat at this point. I think it's really tech-assisted automation at this point. There's technology out there that weighs the tablets, knows that your count is exactly on or not by the weight, knows that you have the wrong tablet by the weight. They go down to, I don't know what decimal point of a gram, but they're like very accurate. There's IT that'll scan the tablet, that'll look for the imprint, that'll tell you if you have the correct tablet on the tray, tell you if there's a spare tablet on the tray that doesn't belong because it's not like the others. This technology is being used by, mail order. The mail order, there aren't many in California, but in other states, they operate at 6 sigma or better, 6 errors per million, and they use all of this technology as opposed to humans. I think the technology is soon going to be cheap enough and available that retail pharmacies will be able to use it, not just huge mail order facilities. And so I think tech might kind of be on the cusp of a thing of the past, and it's more technology or technician-assisted technology where there is no pharmacist second check because it's the tech working with the technology that is the check. Thank you.
Thanks, Mark.
Hi, Lindsay with CRA and NACDS. Just 2 quick points. So I think there are 8 or 9 other states where techs can do the tech product verification. A couple of them it's only for retail, but the rest they can do it. Other thing, I echo Mark's comments. I think we would be supportive in concept, but I don't think that it would really be meaningful without a change in the ratio, the pharmacist to pharmacy technician ratio. It's 1-to-1 right now, so there are a lot of settings where this wouldn't even be able to be utilized. I know we'll talk about that later in the agenda, but I just want to make that point.
Thanks, Cynthia. Okay. Moving on. Oh, yes, thank you. Moderator, will you please open up the line for our Webex participants to comment if they so choose?
Absolutely. If you're on Webex and would like to comment, please drop the word comment into that Q&A panel. Or for our call-in users, you may dial *3 to raise your hand. Our first comment comes from Jeff Olson. Jeff, I've sent the request to unmute your microphone. I see that you're unmuted.
Oh, sorry about that. I was double muted.
It's okay.
I wanted to clarify one thing on the last topic before we start this one. Is there any provisions that prevent a pharmacy technician to provide education to patients on the use of medical equipment?
Hi, this is Eileen, the board counsel. That's not really been agendized, so if you have some questions with respect to some of the specific provisions of pharmacy law, maybe ask the inspector or contact pharmacy board staff.
Okay, understood. Just a few comments then. The pharmacy technicians, at least in an outpatient setting, I believe that refill validation doesn't really require much of a clinical role in order to perform those tasks. Ensuring that the medication, the bottle, the label matches what you're feeling. There is a lot of automation in both settings, in inpatient and outpatient. I think the use of robotics and other automated devices that can help capture and validate each step effectively can be done with a technician. Obviously, a first fill, any other situations that require any clinical judgment should be done by a pharmacist and not a technician. And yeah, I think that was my only additional comment. Thank you.
Thank you, Jeff.
Our next comment comes from Jazzy Graywall. Jazzy, I've sent the request to unmute your microphone.
Thank you. Jessie Graywall with EFCW Western States Council. Just wanted to express our opposition to having another technician supervise or verify another technician. As we all know from the workforce survey, retail pharmacies are completely overwhelmed and overburdened with work. And an additional task, I think, that liability on the first technician as well as on the pharmacist is huge. And so I think it really warrants a further discussion on how this would actually play out in the various practice settings, and really support the comments of the previous speakers who have expressed opposition in the retail setting, given that there are other backstops in the hospital setting, for example, that aren't in the retail setting. Thank you.
Thank you, Jazzy.
Our next comment comes from Jocelyn Frederick. Jocelyn, I've sent the request to unmute your microphone. You will need to click the unmute me button that appears at your end.
Window open as well. I am a farm tech supervisor in a hospital in California, and my concern about tech check tech, particularly for final, is liability. I haven't heard any real discussion on legal liability for technicians. We don't carry liability insurance ourselves, and I don't know how something like this would affect us should an actual error occur. Has there been this places where this is being done, the studies? Do they include any of this information or how it's playing out?
I don't have any answer to that. I think that's a good point, and if we move forward, it's something we should take into consideration. So thanks for bringing it up.
Our next comment comes from Lori Walmsley. Lori, I've sent the request to unmute your microphone.
Good afternoon, board members. Again, Lori Walmsley on behalf of Walgreens. I kind of echo Mark's comments from CVS and would point your attention to the Arizona rule that Bill Cover addressed earlier this morning. I am a board member myself, so not speaking as a board member, but just for informational purposes. My board adopted rules back in 2018 titled Technology Assisted Verification of Products. And what this addresses is specifically the use of technology in the product verification. So I do think that this is a good model that we've seen some benefits with. As Mark mentioned, this is used by many of the mail order pharmacies, of which we do have many in Arizona. So I would encourage you to take a closer look at that. It does address the fact that it can't be a new technician. It requires 1,000 hours of training. Our technicians are certified in Arizona, and then there's some other safeguards and guardrails around that. So if this is something that you'd wish to move forward with, I do think that this is a good model that you could start with as a starting point to look at.
Thanks, Lori.
And that concludes our request for comment at this time.
Okay. I mean, it seems like we're kind of indecisive on how, whether we want to move forward with that, I guess. I don't know. I guess the future, maybe it can be brought back, or I don't think there's clear guidance that we want to move forward with it or not. Oversight is the next thing I just kind of want to touch on. It's probably not anything we're going to solve today, other than I just want to bring up that it was very interesting, the perception of oversight in definitely the listening sessions, but I think it even came through on the surveys, and that was that the technicians felt that they had their oversight, the pharmacists were doing a good job of supervising them and taking care of them. And even during the listening sessions, quite a few of them said, I have ready access to my pharmacist, and they're always ready to answer questions for me, and I think they do a great job of supervising me. And then the pharmacists, as we've heard, kind of weaved in our conversation today, the pharmacists, on the other hand, felt like they maybe didn't have as much oversight as they would have liked. So it was a very interesting situation. And like I said, I'm not sure we're going to necessarily figure it out today. It might be something that needs to kind of be teased out or figured out, as we go forward through this process. But with that, I just want to see if there's any, general comments that any of the board members, committee members want to make.
Let's go. Well, so today, one pharmacist can only have one technician in the pharmacy that can pull and count. I can have 3 other technicians doing clerical job. Correct?
Yeah.
And from the discussions, it sounded like pharmacists could have 2 technicians counting in a pharmacy, and that would be okay with them. And they're saying that for better work condition, to get their job done, and that's not a barrier. So I feel that increasing that ratio, it's not going to hurt. In one of the presentations I saw that was at South Carolina, if I think they allowed that ratio to be higher if the technician is certified or something like that. So, I mean, I'm for entertaining that motion that, if there are 2 technicians that are counting under one pharmacist, I don't know how that's going to hurt the consumer. If the working condition is pharmacy is better, then they're able to provide service efficiently and accurately, and I think it benefits everybody, including the staff in the pharmacy.
I mean, I think we do have a placeholder here for ratio, which is, I think, where you're going with that. And perhaps that is where this needs to be. Yeah. You good, Cheryl? Is there anybody here at Market Street that would like to make a comment on oversight? Shane.
Hi, Shane. So I'm a little fuzzy on what exactly we're discussing with regards to oversight. But I know there's something that leads in the ratios. But I just wanted to, you made a comment earlier about pharmacist supervision, and again, there's a number of studies that indicate that exactly what you stated, that technicians are extremely happy with their accessibility to pharmacists and the way that pharmacists are managing them in terms of the camaraderie and so forth in pharmacy. What technicians have indicated is lacking a little bit is what might be called transformative leadership by pharmacists, which is really taking an investment and developing them further in their careers. But in terms of like the relationships, the collegiality, their accessibility, the technicians have been reportedly really happy with that, as have pharmacists. But again, the purely higher stages of leadership are maybe a little bit lacking.
Thank you. You want to speak, Mark? Okay, Mark?
Mark Johnston. First off, I think we're talking about supervision, and I think California has an excellent definition of direct supervision and control, meaning the pharmacist is on the premises and is aware of the duties that the technician is doing and doesn't have to hawk over the top of the technician all the time. Now, of course, that might have to be addressed if we're talking about remote work, which is upcoming. But I also wanted to maybe assist with some of the liability questions, just because we went through this in Idaho too. So we contacted Pharmacist Mutual, I think the largest pharmacist insurance company, and we asked them if tech and these advanced tech duties would increase liability to the point where there would be increases in premiums and whatnot. And they said no. It's right in the minutes of the Idaho board meeting. It was Ken Baker at the time. God rest Ken's soul. We all loved Ken, who appeared and gave the presentation in front of the Idaho board. And also, this board has talked about this in the past with prior efforts. But the Idaho board and the overwhelming way that boards are starting to look at this is that technicians have a license, and you hold the technicians accountable for the duties that they do, and certainly the supervising pharmacist has a role here. But the supervising pharmacist is not the only license that is in a liable situation from a board of pharmacy perspective. If you give techs duties, it comes with responsibility, and and their licenses can potentially be held accountable more than they may have in the past when they didn't have those expanded duties. It's kind of the concept that most states have bought into now.
Thanks, Mark. Okay, moderator, will you check and see if we have anybody in our Webex crowd that would like to make a comment?
I'm looking. As a reminder, if you'd like to comment on this one, please use that Q&A panel to submit the word comment. If you're a call-in user, you may dial *3 to raise your hand. And I'm not seeing any requests for comment.
Thanks, Ms. Moderator. I'm going to move on to the next thing I want to chat about is training. That was something that we specifically asked about and came up. Let's see, and this is another area that there was a difference between pharmacists and technicians, kind of as a rule of thumb. The technicians felt like their training had been, for the most part, okay. They definitely felt like they needed, additional training for certain duties like administration of vaccinations. The pharmacists thought that perhaps additional training, and I think both of them brought up, CE. Maybe there's some CE that should be done, but overall, they both agreed that the training requirement should be based on the duties. And kind of just going back to what our current law, just give me a sec here. So our current law around training does have provisions for a course of training to be either completion of a training program accredited by American Society of Health System Pharmacists or pharmacy technician training program provided by a branch of the Federal Armed Services, or any other course that provides training period of at least 240 hours and instruction covering specified areas. And I guess my only comment is based on what we heard today, perhaps we need to just look at that and fine tune it, but I'm not sure that there's a major overhaul here needed. It's I also, a couple people from, I think it's mainly the UFCW, said let's not create barriers. I'm 100% with them. So we might want to dust it off and refine it a little bit, make sure we get the level of training we need, but I'm not sure that we need to blow it up. Anybody else have?
I'll agree with that.
Okay. Any comments from the public here on Market Street? We have Tom coming up.
Good afternoon, Tom Harper. So I agree with you. I went to school 12 years ago, and I felt that my training was adequate. I've been able to work at every institution possible. I've worked in certain retail, went to institutional, went to hospital. Now I'm a program manager. So I feel that that the training is it's relevant. I don't think we should mandate. I know a lot of states require ASHP accreditation. I don't think we should mandate I think that just hinders the education. I think facilities, you know, if you have sterile compounding, facilities have the option to, you know, provide additional training to their staff once they're onboarded. So I don't think, you know, the board should, you know, make any more additional requirements for training. I think it's adequate as is. I think the 240 hours, what states now, it's doable for technicians, especially new technicians. If you require the AA, like some of the states do, that's, you know, that's another year and a half of schooling, which I don't think technicians are going to be willing to do. So thank you.
Thank you, Tom. Okay, Ms. Moderator, will you please check the Webex and see if we have any comments on the participants in the Webex?
Absolutely. We have our Q&A panel open. And as a reminder, you can use that Q&A panel to submit the word comment or dial *3 for our call-in users to raise your hand. And I'm not seeing any requests for comment at this time.
Okay, thank you. All right, moving on, the next thing that was in the questions was, you know, what are your biggest challenges? And honestly, I thought this was going to be a huge dumping ground, and was not. Neither the pharmacists nor the technicians. Probably the most common thread that we heard, if someone spoke to it, was, you know, workload and staffing. Like there's not enough technicians. And, you know, so it's, you know, hopefully what we're doing is we're going to make it a job that people are more interested in doing, and so we'll help fill that. I think it's also a little bit of result of COVID and some of the tech schools, because we also had some people from tech schools that said their classes are really small right now. But I'm not sure specifically what came out of the listening sessions in the survey. There's not a lot there for us to act on. Anybody else have any? I'll throw it back to the public here.
Shane Saltero, University of California. Yeah, some of the things that you've mentioned, you know, salary and so forth, but actually in national studies that have been published, what's come up time and again as the biggest complaint, if you will, among technicians is lack of advancement opportunity. That's showed up probably, if there's 12 studies that have evaluated, it's showed up as all 12 as number one.
Interesting, thank you.
Jeannie Lee again. I think that we're getting the shortage of pharmacy technicians now, and you can use COVID as a excuse for them not wanting to work anymore, but in reality, technicians now are making very less money than what In-N-Out Burger is paying them. So they're looking to leave pharmacy to go work at some place that's going to give them more money. I'm at the top of the pay for the state of California, and I'm not going to get any more than $21 an hour unless I get the cost of living factors put in. But that's not something I'm going to be able to live on when it comes time to retire, because that's not enough for me to support me and my husband, that I had to leave pharmacy, but stay in pharmacy, but doing a different job, just not a pharmacy technician as my title, but I still do pharmacy tech stuff. But we have to look at what, and I'm not saying the board has to do this, because it's not your guys' responsibility, right. But we have to look at those chains who can make the difference and start paying the people, the technicians, what they deserve. Because if we're supposed to be licensed as a technician, we should be respected as a technician, a professional, than an In-N-Out Burger flipper. Thank you.
Thank you. Okay, Ms. Moderator, can you please open up the Q&A panel and see if we have any commenters on our Webex?
Absolutely. Our Q&A panel is open. You can request a comment by typing the word comment and sending that through, or dial *3 to raise your hand if you're a call-in user. And not seeing any requests at this time.
Okay, thank you. I'm going to keep pushing since you have to leave. I'm not going to take a break. Okay. So the next item is remote work, and under the board's waiver, pharmacy technicians are authorized to perform remote functions under specified conditions. However, it appears that authority does not appear to be widely used. Most of the pharmacy technicians reported that they did not perform remote work, and it was kind of like one group of technicians that did use it, and they loved it. They tended to be either PBM or like mail order technicians, but all the technicians that reported that they were hospital or retail, none of them indicated that there was any kind of remote processing happening in their work site. Not that it couldn't happen in the future, but that's just, the feedback we received. So it definitely seems like something that probably in the future, because, we're hearing other states are doing it, so it seems like something in the future, but from this collection of data, we've got very little on this. Public, is there anything you would like to comment on? Lindsay?
No, again. So I think that we do have members that did or do utilize remote processing waiver, and I think that if that was something that was made permanent, we would probably see higher utilization. Obviously, it's a newer thing, but I agree in looking at the survey results, it did seem like a lot of techs, in addition to pharmacists, want to be able to use this. And I know that when the board discussed this in January, whenever it was, the proposal that you voted to pursue was just limited to pharmacists. But I do think that if it's great that we're having this discussion, and if this is something that happens in the future, especially based on these survey results, it looks like it would be great to include techs if we could.
Yeah, I would tend to agree. I think when we did remote processing, we said, well, let's wait and see what happens from the tech summit, and then we've gotten from the tech summit, so it's probably remote processing we need to.
The math was removed too today, remember?
What's that? Yeah. So it's probably something we're going to have to look at all together at a future time. Yes, Mark.
Mark Johnston again. CVS Health has many different business units with Quorum, with Omnicare, with specialty pharmacies. So it isn't just retail. And some of these business units around the country use a lot of work-at-home labor. The hesitation in California with just a temporary allowance is that when the temporary allowance goes away, these folks have to live close enough to the pharmacy that they actually will commute in. They may live an hour away. Heck, they may live in, 8 hours away in a state as large as California and be able to remotely work for a pharmacy. But you can't hire somebody 8 hours away and then have a temporary allowance go away. So it's probably why you haven't seen buy-in like you do in some of the other states. I really do believe that remote work is the key to so many issues. First off, diversion. With the inventory reconciliation rules, California is obviously concerned with diversion. If the hands aren't in the pharmacy, nobody can divert. The next thing is ratio. These folks are filling a queue of work for a pharmacist to do when they have time at their pace. There is no real need for supervision. There is no camera in somebody's house. They're just filling a queue up. And so they can solve the ratio and supervision issues, which are workforce issues. I mean, there's real workforce issues that have been mentioned numerous times today. And if you take the people and the work out of the pharmacies, you solve the workforce issues. Now, the fears, which have been unfounded through the pandemic when 45 states allowed techs to work at home, and there's plenty of permanent work allowances, are what, techs are going to be working in their pajamas, or, techs are going to be, drinking alcohol while they're, or their kids are going to get at, HIPAA data on their computer. I mean, all of these are what ifs that are totally unfounded by, years now of technicians and pharmacists working at home. So I really think if there's a spot to be, I want to say progressive, but maybe it's behind the progressive curve already. If there's a place to be, liberal in allowances, I really think remote work at home is the key to so many of the issues that we know exist. Thank you. This might be my last opportunity to talk. I just wanted to thank the board for a great day. It's been great conversation, and maybe reiterate the point that Bill made at the end of a meeting, Bill from NABP, that, it takes all of us working together. We're all pharmacists, and technicians. We're not independent pharmacists or retail pharmacists or hospital pharmacists. We're the profession of pharmacy, and it takes us all together to solve big issues like this. So thank you.
Thanks, Mark. And you kind of reminded me, because that one of the comments we heard of the people who were using remote processing was a bunch of them didn't live real close to the pharmacy, and they were actually quite worried about what was going to happen when the waiver expired, because they verbally said, I'm going to have to now drive 2 hours each way to work. And they also all liked the fact that in a pandemic, they didn't have to work close to other people. They felt like it was safer. Ms. Moderator, is there any people in the queue, or can you put up the queue and open up the Q&A to see if we have any people in the Webex that would like to comment on this topic?
Our Q&A is open. You can submit the word comment through the Q&A, or you can raise your hand. Our first comment comes from Jazzy Graywall. Jazzy, I've sent the request to unmute your microphone.
Good afternoon, Jessie Graywall with UFCW Western States Council. UFCW has significant concerns when it comes to remote processing, not only for pharmacists, but also pharmacy technicians. We strongly believe that there are significant concerns that can happen when you have a technician at home away from the pharmacist, and any mistake that is made in the remote work at home, that liability does ultimately fall back on the pharmacist, who is not there to supervise what that pharmacy technician is doing. We have also heard anecdotally from our members that not a lot of our members have done remote processing, but we have heard of some facilities that have allowed it, and there's concerns around lower pay. How does additional work, so if you're coming into the pharmacy and then you're doing remote work at home, how many hours are you working in that day, and making sure that we're not continuing to overburden the profession. There are HIPAA concerns, not just children accessing their parents' computer and seeing sensitive data, but you might have individuals in your home that see your computer from behind the screen. And so there are significant concerns when it comes to remote processing related to pharmacy technicians as well as pharmacists. And so UFCW has been formally opposed to that. I think something that we have considered is there remote work from another licensed facility? How does that work? So you have a licensed facility, we're able to control that workforce setting and be able to have a supervising pharmacist on site to supervise that remote pharmacy technician. But in an unlicensed facility like someone's home, there are significant concerns that we have. And then even more concerns when it comes from a pharmacy technician that might be working in a bordering state like Arizona or Nevada and processing prescriptions in California. And we only have concerns within the retail setting, as that is the setting that we primarily represent. Thank you.
Thank you, Jazzy.
Our next comment comes from John Gray. John, I've sent the request to unmute your microphone.
I'm a registered pharmacist with Kaiser Permanente. Thank you very much for the opportunity to provide feedback on this important topic. First, we'd like to continue to encourage the board to seek a statutory change to permanently allow pharmacists in charge to authorize pharmacy technician remote work in a manner similar to the board's current pharmacy technician remote work waiver. It's noteworthy that staffing challenges were flagged as among the most significant challenges during the stakeholder listening sessions, and we believe that allowing PICS to authorize pharmacy technician remote work could be one option to bolster the pharmacy technician workforce. We also continue to encourage the board to work to remove the current statutory and regulatory barriers to licensed pharmacy technicians performing non-discretionary tasks under the direct supervision and control of a pharmacist outside of a licensed pharmacy. Specifically, Section 1793 of Title 16 of California Code of Regulations and Section 4038 of the Business and Professions Code should be amended to remove the reference to pharmacy technicians working exclusively in a pharmacy. There are numerous tasks that must be done for pharmacists who work outside of a licensed pharmacy to provide cognitive services and patient care services that do not require the education, expertise, training, and specialized knowledge of a pharmacist. In most cases, pharmacy technicians routinely perform these tasks within a licensed pharmacy. Some examples are things like obtaining and entering information into the patient's pharmacy profile, obtaining and documenting medication histories, which is currently allowed in the hospital setting, and communicating with other members of the patient's healthcare team. The documents provided by the board in the related research packet highlight the fact that pharmacy technicians are more than qualified to perform tasks like this. For example, the study by Arison and colleagues demonstrated pharmacy technicians' ability to take and gather accurate medication histories. Therefore, we believe that those tasks that pharmacy technicians already perform within a licensed pharmacy, technicians ought to be able to perform those tasks under the supervision of a pharmacist outside of a licensed pharmacy, and therefore we encourage the board to remove these artificial barriers to pharmacy technician practice outside of a licensed pharmacy. Thank you very much for convening this session and the listening sessions, and thanks for the opportunity to provide our comments on this critically important subject of the future of pharmacy technician practice in California.
Thank you, John.
Our next comment comes from Lori Walmsley. Lori, I've sent the request to unmute your microphone.
Thank you, moderator. Thank you, board members. Lori Walmsley on behalf of Walgreens. We too are supportive of the board considering the addition of technicians for work at home. As I've mentioned in prior meetings, we've used this across the country throughout the pandemic and in many other states where it has had permanent allowances, and have seen that this adds flexibility for our team members and can actually work to improve working conditions and things like that for individuals that may need alternative work environments, for people that need more flexible schedules, working parents, things like that, that may wish to work for a few hours, take care of their children, and then come back and work for a few hours. I definitely think that this provides an opportunity for us to expand the workforce for California and do so in a way that's safe and helps to support the team members that are in all of the different types of locations. So again, we're very supportive of this. Thank you.
Thanks, Lori.
And our next comment comes from Jeff Olson. Jeff, I've sent the request to unmute your microphone.
Thank you so much, Charlie. I'd like to agree with the comments made by John Gray. I think it was eloquently stated. In my organization, remote work during the temporary waiver was very helpful in ensuring staffing needs. During the surge, pharmacy saw a lot of prescriptions being processed at the time, making it very difficult to process everything in a reasonable amount of time. Without remote work, we would have saw a sicker workforce, labor shortages, patient care delivery issues. I fully support remote work for pharmacy technicians and what they do. There's a lot of benefit to that, I think, for patient care and also for struggling to get staffing in our settings. Thank you.
Thank you, Jeff.
And with that, I do not see any further requests for comment at this time.
Okay, thank you. I think as a board, remote work, since the bill that the board was trying to push through the legislature has died, maybe as that comes back up, the board can consider if they want to do pharmacists and technicians at the same time. So I just, this will be to be continued. Moving on to our next agenda item, which is discussion and consideration of the current pharmacist to pharmacy technician ratio and possible changes. This is our last item to chat about. And currently, our current provisions actually date back quite a while, back to, according to my notes, July 2017, where a committee discussed and appeared to conclude that a technician ratio of 1 to 2 appeared appropriate. However, at that point in time, no action was taken. The question was not included in the survey. However, ratio did come up by both pharmacists and technicians. And once again, I was kind of surprised. Quite often it was the technicians that were saying we should have, the ratio should be increased because it's too low. I don't remember the pharmacist really, it came up. I don't remember it being a negative thing. I remember it being more of a positive, but that could be my failing. So at this point, I'm just curious if the board members have any thoughts that they want to make. My thought, I'll start off, is I think that the time has come for us to look at the ratio. I think in the data, like there's like 20-ish states where there's like no ratio. We were the tightest ratio in the nation, where we are 1 to 1, and when the second pharmacist comes in, it's 2 pharmacists to 3 technicians. So I think that other states and time has shown that there's not a challenge, there's not a safety issue, and I do think that the additional technicians would allow the pharmacist to practice at a higher level. I know that there's always a concern that the corporations will take advantage of the situation. I don't really think that that's necessarily going to happen, but that's my opinion. So I'll pass it off. Do you want to go next, Song?
Sure. This is a tricky issue, as we all know, and I am kind of in the middle of it, and I can support certain changes to ratio on certain situations. So I wouldn't know if I could support a broad just stroke of 1 to 2, whatever it is. I think that's arbitrary number, doesn't mean anything. So, I think we have to take a deeper dive, not in just this session. It'll be another day for a licensing committee for us to discuss this in a more thorough way. But I can see some support in, when a technician is engaged in immunizations, like how we did a waiver, maybe we can allow that as a permanent authority. Or, if we could have some sort of floor, not just ceiling, so we could always ensure pharmacist has a technician available at all times. So I think that I could be in supportive of certain situations like that.
I just want to say I think that's a great idea. I have a floor. And we kind of have that, right? But.
Yes, really quickly. I'm curious to hear how adding more techs for a pharmacist to oversee will, right now they feel like they can't oversee the number of techs they currently have, but adding more techs that in theory should give them more time to do higher level work. Is that what we're looking at here? Okay. All right. That's all. Thank you.
Jig is always good about explaining these things.
Explain more. Well, I'm in support of.
I would just say, as Jason said, I'm trying to understand how they're having a hard time overseeing 1 to 1. How, if we gave them more technicians, how that would be positive. And you've been a very good teacher, so I think I'll let you handle it.
Well, in a pharmacy setting, if I have one person that can only count, I'm a pharmacist, I'm doing consultation, I'm making sure, the vaccines are being consulted and everything else. And if my technician, let's say right now they're giving COVID shots, has to give COVID shots, then I could have another technician start counting, and the work continues to flow. But right now, due to ratio, because I have one technician already doing technician duty, which is vaccination, that counting prescriptions comes to a dead halt or I have to jump in as a pharmacist myself. But if I have the ratio of 1 to 2, the second technician can step in and start counting. So I could do my clinical duties and continue to do the consultations and talking to doctors or whatever else I have to do. So it does open up the pharmacist to do the higher level work.
And I'd like to say, I've talked to many pharmacists about this, and over the years, and I was actually surprised to hear some of them tell me I'd like to have another tech, because of their workload. So, but again, it's the liability situation, and then I also think about the fact that, of course, if they're doing COVID shots, and the pharmacists need to watch, then certainly, we've allowed that. So I just feel like we should go somewhere where certainly when if they're going to be given the vaccines, that we certainly definitely need to be able to have the 2-to-1, so that we don't have a situation where one tech is running to the back to give vaccines, pharmacist is doing a consultation, already you have distress and anxiety going on. So, I do hear the pharmacists that have told me I could stand to have some more help, but also I've heard the concern about the liability, so I'm kind of in the middle with that one also.
Thank you. Okay. Should I open up to the public? Okay. So let me open it up to the public here on Market Street.
Hello again, probably the last time I'll comment, and it has been a great day. I echo what Mark said. I think this has been a really good discussion, and I'm glad we're having it. And on this topic, I do think that it needs probably a broader discussion as well, but I'm glad that we're starting the discussion. We're continuing it from prior meetings. There's a lot of things about the ratio that we support, and we definitely think that it needs to be expanded. And Debbie, like you said, I think maybe 23 states have no ratio. A lot of states have an 8-to-1 or a 6-to-1, maybe a 4-to-1. A couple have a 2-to-1, but 23 have none. And I understand that that's not necessarily what we're looking at here, and we want to make sure that there are guardrails, but I think it really is a workforce issue. We've all talked about workforce shortages. We've talked about it at the Medication Error Ad Hoc Committee, and I think this is one way to combat that. There's a shortage of pharmacists. This just opens it up a little bit so that there's additional workforce. This aids the pharmacists so they can do non-discretionary tasks and focus on their clinical duties. And I looked at the survey results as well, and from what I saw, it was both pharmacists and techs who wanted to see an expansion. So I just definitely am happy that we're talking about it, and we'd love to remain engaged in the discussions and be a resource however we can. Thanks.
Thanks, Lindsay. Shane.
Hi, Shane DeSale. I just want to reiterate Lindsay's comments. I comment on the literature because that's what I do. I look at studies and whatnot, and obviously this is something that's very difficult to study. Like what would happen when you change ratios? So that it's not really something that's reported directly in the literature. Indirectly, many legal authorities, clinical authorities have spoken very highly of improving of expanding ratios, and where it has, again, it's more anecdotal than studied directly, but there's been very high levels of satisfaction and reductions of stress, reductions of turnover, and so forth, and thus improvements of safety on a anecdotal sort of commentary sort of level in that regard. So I just want to reiterate support for that.
Thank you, Shane. Ms. Moderator, will you please open the Q&A panel and see if we have any comments coming in from the Webex crowd?
Absolutely. Our Q&A panel is open. You can use that panel to submit the word comment if you'd like to make a public comment, or you can dial *3 to raise your hand. And our first comment comes from Jeff Olson. Jeff, I've sent the request to unmute your microphone.
All right, thank you so much. Yeah, I believe the staffing ratios, as they are set, are very limiting to the pharmacists, and I think that it makes it difficult for them to do their job. Essentially, when they have to take care of the patients, do their clinical work, manage and monitor staff to make sure that they're not out of ratio. I think that puts them in a bad situation. I really think that the pharmacist or the pharmacist in charge really knows their staffing needs the best in terms of technicians that they need to perform the work effectively. So I'd be in favor to open up the ratio, obviously with guidelines that are safe and responsible. But essentially, I think those who know what they need are going to be the pharmacists supervising other technicians. Thank you.
Thank you, Jeff.
Our next comment comes from Jazzy Graywall. Jazzy, I've sent the request to unmute your microphone.
Thank you, Jassy Graywell, Legislative Director with UFCW Western States Council. On the tech ratio, on the ratio discussion, what UFCW would like to add is that there really needs to be a discussion of a staffing floor. We worked on a bill a couple years ago, SB 1442, to ensure that there was support in the pharmacy for the pharmacist who was who we were hearing and the work for our survey results really showed is that you had pharmacists who are working alone for multiple hours by themselves. And so as we talk about increasing the ratio, we really need to talk about what minimum floor level is there to ensure that pharmacists have the support that they need. And then also talk about what does a ratio look like when it comes to services that pharmacists provide, as well as the prescription side of their duties as well. If pharmacy technicians are performing services around the corner from the pharmacy or in a closed room, how does supervision look like in that capacity versus a pharmacist who has another technician in the behind the counter with them? We still struggle to have support for the pharmacists with pharmacy technicians. Our pharmacists are still really working alone and sometimes with a clerk, but oftentimes not with one. And so really urging the board to consider what does a staffing floor look like given the prescription volume and the service volume within the different pharmacies that we see.
Thank you, Jazzy.
Our next comment comes from Lori Walmsley. Lori, I've sent the request to unmute your microphone.
Good afternoon, Lori Walmsley on behalf of Walgreens. Again, I would like to echo the comments of many of the others. Thank you for the outstanding, thoughtful, deliberate conversation on this very important topic today. Can't thank the board enough for your discussion here today. We are in support of the expansion of the ratio. I would suggest that the board take a look at language similar to New Mexico, which allows the pharmacist in charge to determine what their appropriate ratio is. No pharmacy is the same. No two team members are the same. No two pharmacists are the same. So allowing the pharmacist in charge or the pharmacist on duty to set what they feel is the appropriate ratio, I think is a good potential solution that would allow a lot of autonomy for the pharmacist to determine to make sure that they feel like they have the sufficient support as well as not being overburdened. Thank you very much for the discussion today.
Thanks, Lori.
And our next comment comes from Paige Talley. Paige, I've sent the request to unmute your microphone.
Talley, representing the California Council for the Advancement of Pharmacy. Are you hearing an echo?
Yeah, a little bit, but it's
okay. I'll stand back further. This is a very important issue for my members because the majority of them are long-term care pharmacy owners, and currently they are allowed to have a 1-to-2 ratio when they're filling nursing home prescriptions, but only that. So they handle ALFs and other congregate living situations, and they cannot be doing them at the same time as they're doing nursing homes. So raising the ratio is vital to them. Thank you.
Thanks, Paige.
And that looks like the last of our requests at this time.
Thank you, Ms. Moderator. Okay, well, we have gone through all of our topics that were discussed in the listening sessions and the surveys. And before we adjourn, I just want to understand, that we've kind of gone through and there's some actions for our next meeting, which is currently scheduled for July 18th. I guess that my understanding of the committee is we just kind of want to move this forward. We've kind of dissected each thing. I believe we've provided the staff with enough direction and guidelines, Ann, so you know where we want to go?
Yeah, I mean, as long as I can continue to work with the chair offline.
Yep. So before we adjourn, I would like, again, to open up for public comment for items not on the agenda. As you may be aware, when the agenda was originally released, unfortunately, the wrong street address was published. And just in case we had some people who joined us after, after fact because of that error, we want to provide them with the opportunity to provide public comments for items not on the agenda. Once again, the committee cannot take action or comment on these things, but only consider if we want to put them on the agenda for future items. Now, we have a small enough group in the room that I know all of you guys were here when we started. So I guess we will go to the Webex people, although I'm not sure exactly how the address thing there.
Before that, I just want to say really quick, Debbie, this is her last licensing committee as a chair, and Cheryl as a member, and they've done an amazing job all these years serving in the committee and running the committee, so I just want to say thank you to both for doing an amazing job.
You're welcome.
Thank you.
You're welcome.
You're welcome.
But first, Ms. Moderator, you want to open up the Q&A panel because they too, even though the address wouldn't have affected them, we are still opening up for public comment on items that were not agendized.
All right, so we have opened the Q&A panel. If you'd like to comment on items that were not discussed on today's agenda, please use that Q&A panel to submit the word comment, or dial *3 if you happen to be a call-in user. We do have a comment from Jazzy Graywall. Jazzy, I've sent the request to unmute your microphone.
Thank you. I also just wanted to say thank you to Cheryl and to Debbie for all the service that they've done on the Board of Pharmacy, to pharmacists and pharmacy technicians all over the state. I know it's not an easy job on top of your professional jobs, but really thank you so much for your dedication and commitment to the board for all these years. California is better off after your service at the board and really moving the profession forward. I don't have any comments for items on the agenda. I just wanted to thank both of them for their service to the board.
Thank you, Jazzy.
Thank
you want
you,
to say anything,
Jazzy.
Cheryl?
And with that, we have no further requests for comment.
And I want to thank my sister for being
my sister from another mother.
right.
It's been fun. Okay, with that, we will adjourn. Just a reminder that the next scheduled committee meeting will be July 18th. Somehow they're going to hold it without Cheryl and I. And we now adjourn. Crazy. Good job. Thank you.